All right, Jim, you're good to go.
Okay. Today we're going to talk a little bit about chronic pain and chronic low back pain specifically. A little bit about me. I'm a physical therapist. I've been working for a little over 13 years. I'm McKenzie certified. I'm certified through the Pittsburgh as a primary spine practitioner, and I also did a movement science fellowship at WashU. And I'm in charge of the chronic pain program at Rehab Specialists. So low back pain, it's incredibly common, and I think this is important for people to know. About 90% of the population will have an episode of low back pain at some point in their life. That's important to know so that you know that like having low back pain isn't an unusual experience for humans, and it's a pretty normal thing. Most back pain does go away on its own. 90% of it also goes away on its own. So if you're here today, I'm assuming you've had it for more than a couple months, and that's why we're here. But most back pain does go away on its own. It generally peaks kind of middle ages. It does not tend to, as far as the population goes, it doesn't get worse with age. We see a higher prevalence of it between like 35 and 45. So this is one thing to keep in mind. As I said, it kind of peaks around 40, and then it tends that we see less low back pain in the population. And I see some stuff in the chat here. Okay. Degenerative changes do get worse over time. So your MRI will get worse, but that doesn't mean that we see more back pain over time. So MRI findings. A lot of you have probably had MRIs, and you see a lot of scary words. You see things like disc degeneration, disc bulges, protrusions, spondylolysis, spondylolisthesis, all these really, really scary words. These are also really, really, really prevalent. If you find your age here and look at how many people your age have these things, these are all individuals without any low back pain. So the point of this is to understand that you can have disc bulges, disc protrusions, herniations, and you can have that stuff and you can have pain with it, and you can have that stuff and not have pain with it. It's not a really good determining factor. What MRIs are really useful for is if you're going to have an epidural, if you're going to have surgery, it really gives the surgeon a lot of information on where to go, what area to give you the shot, what area to do whatever procedure they're doing. But it's not very predictive of who's going to have pain. They also did a follow-up with this study that I don't have shown here, but they tried to determine over the next 5 to 10 years who is gonna develop pain. So these are all individuals without pain. Well, maybe the people that look worse on MRIs are more apt to develop pain. And that's not what they found. They found that there was not a correlation between how poor the MRI looked and how bad it got over time. That doesn't mean your pain isn't there. It doesn't mean it's not real. It just means that don't get too concerned about the MRI findings. Be concerned about your symptoms, but the MRIs aren't good predictors of who's going to have symptoms. So again, we're talking a little bit about the imaging findings. I'm talking about this a lot because this tends to scare people a lot. They see these things on MRIs, and then it's like, oh, I'm going to have pain for the rest of my life, and that's not necessarily true. So what we have here is we have a study where they looked at massive herniations. These aren't normal disc bulges. These are ones that they considered massive, and they did nothing with them. And they followed them for 2 years. And after that 2 years, what they found is that most of those disc herniations healed. So if you've had those diagnoses in the past, that doesn't mean that you're always going to have a disc herniation. The body's pretty good at reabsorbing that. The interesting thing about this is that there was no correlation between who improved on MRI and who actually got better. So you could get better on MRI and your symptoms might not improve. You could improve on MRI. Your symptoms could get a lot better and your MRI might look the same. Most people improved in both factors, but the changes on MRI did not correlate with how people were feeling later. So why do I bring this all up? Why are we talking so much about imaging and what they're finding? Because when people hear these things and when they see their imaging results, it changes how they feel about their back. And that actually changes their function. So what we have here is we have days of disability. And they divided them up between people with radicular symptoms, people with symptoms going down the leg, or individuals with just low back pain without any symptoms down the leg. So we looked at that. Then what they did is they looked at who had an MRI and who didn't have an MRI. It turns out that if you had an MRI, you did worse. There was more days of disability. There was more medical costs. So the study that this came out of is it's iatrogenic causes of low back pain or something like that. And what they're basically, the preposition of the study is that our imaging and our knowledge of the back actually makes it a little bit worse. We tend to get a little more afraid because we know how bad our back is, and that actually tends to scare us a little bit more. So we do less activity. I had someone that had a disc herniation 20 years ago, and most of their pain resolved, but they gave up everything that they had loved to do, and they gave it up because they knew how bad their disc herniation was. They went back 20 years later because they had a little bit of pain and they wanted to get over it, but it wasn't that severe pain they had before, and they had given up everything. And I got them better in 3 visits because I just explained to them this, and we just started doing those things that they had been avoiding doing. So they just started exposing themselves to bending forward, doing some of that stuff that they hadn't done for a long, long, long time. It also changes how we hold ourselves and how we, people tend to tighten up and tense up more when they're more afraid. So again, this is days of disability. So these, I wonder if, so the bottom lines right here are how many days if they didn't have an MRI, and these top 2 lines are if they did have an MRI. And then the difference between the reason there's 2 lines below and 2 lines above is that's whether they had symptoms down the leg or not. So fear makes things worse. We've known this since like the 90s. This is one of the biggest predictors of if people get over low back pain or not, is do they believe they're going to get over low back pain, and how afraid are they? And that's what we found time and time and time again. It doesn't mean the physical factors aren't important, but it's kind of it's all of it together that's really important, and we'll get into that a little bit. Fear also increases, again, trunk muscle activation. We tend to guard more. We tend to be more protective. So I want you guys to all try something for a second. We're going to do something to protect your wrist. We're just going to have you make a fist, and we're just going to have you hold that stiff for the next hour and see how that feels, or try to move it around a little bit. I doubt many of you are doing that, but you can imagine, how's your wrist going to feel if you're tense for a long time? It's something to think about. When you do have an episode of back pain, it's important to remember that this is a normal human experience. About 90% of the population will. So the brain decides whether we have pain or not. This doesn't mean your pain isn't real. This doesn't mean the physical factors don't matter. That disc herniation may be a big factor, but we can upregulate it or downregulate it. So we have something called ascending inhibition. When we think that there's danger, so I don't know if any of you guys have been to the doctor and they give you bad news and you start to hurt a little bit more, or they give you good news and things feel a little bit better. That's what this is. It doesn't get rid of it. It doesn't create pain out of nowhere, but it can make it a little bit worse or a little bit better. So when we're afraid of this, it actually increases pain. It increases kind of that fight or flight system. There's a whole plethora of stuff that goes on. We move differently. Other factors that produce chronic low back pain. Smoking. Smoking is horrible for the discs. It creates disc degeneration. It's awful for them. Obesity. The interesting thing about this is we're not actually sure if it's the weight bearing or if it's the increase in inflammation. We think similar to diabetes that some of the reason we see more pain in people that are overweight is because they have higher inflammatory levels. And that's the reason that diabetes exists too. It's that abdominal obesity increases inflammation throughout the body. Sedentary lifestyle. So just being inactive. And again, fear can play into that a little bit too, but that can just be a lifestyle factor. Depression and stress at work. These tend to be bigger factors than your hamstring length or your muscle strength. These tend to be the bigger factors. Things that help exercise. Physical exercise. So doing every kind of exercise helps. So one of the things that we found that across the board, kind of, if we do yoga, if we do Pilates, if we do resistance training, if we do running even, all of these have been found to help low back pain. And actually, they're about as effective as some of the physical therapy exercises that we're given. So one of the big things that I try to do is tell people, what do you like to do? What do you, when we're done with physical therapy, what do you want to do? What do you want to get back to doing? What kind of exercise do you enjoy doing? Because instead of just having you do mat exercises, that are kind of boring, I'd rather, unless you need that, some people need that, I'd rather you take a spinning class. I'd rather you take a Pilates class. I'd rather something that'll keep you engaged. Or if you like hiking, or if you like running. Running's a really interesting one. I hear a lot from a lot of patients, so I don't want to run, I don't want the compressive loads, but the research actually shows with running that the discs get stronger. The outer annulus actually strengthens. That's what the research is showing. There are some people that have pain with running, and that's a different circumstance, but if we take 20 people with chronic low back pain and stick them into any kind of exercise program, at the end of that group is going to be doing better. Physical therapy. There's a lot of different physical therapy styles of physical therapy. There's spinal manipulation. Generally, that's associated with chiropractors, but PTs do it as well. There's McKenzie exercises, which is repeated motions. We'll go into more of these in a minute too. Core stabilization and graded exposure. Graded exposure is kind of interesting. And so what they did is they kind of took the activities that were painful to people, and instead of doing stabilization or avoidance with them, they slowly had them do more of those activities. And that was just as effective as core stabilization was. Actually slow graded exposure to the painful activity and exercise. This is in a stepwise fashion. Understand, this is not just go do that thing that hurts you all the time. This is kind of do a little bit, back off, do a little bit more, back off, do a little bit more, back off. General exercise, yeah, we already went over that. Acupuncture is also helpful for some individuals, and meditation and cognitive behavioral therapy are helpful for low back pain. Let's see. Have to let some people in. Okay, so we're kind of halfway. We've already started, guys, but you haven't missed too much. So we'll continue on. Passive versus active coping strategies. This is right up there with fear, depression, all those kind of predictors of who gets better from low back pain, who doesn't get better from low back pain. So if you have passive coping styles, you're not as apt to get over your low back pain as if you have active coping. So active coping is if you're in pain from sitting for too long, getting up and going for a walk. If you're in pain from standing for too long, doing some stretches. If you're stressed out, doing meditation. Passive coping is more of taking a pain medication, using ice, using heat. Those are good adjunctive therapies, but they're not. The research is showing that they're only kind of giving you temporary relief. They're not what's going to get you over this. So active versus the passive kind of approaches that are more effective. Acupuncture, massage, joint mobilization, and traction are probably the best. But what I would say is if you're just doing those things and you're not actively involved in getting yourself better, you're probably not going to get over your episode of back pain. And when I say all this stuff, every individual is a little different. This is what we found on kind of a population level. Self-efficacy. So this is related, again, to active and passive coping, but it's how engaged are you in getting better. So self-efficacy is do you continue to try? Do you continue to try to push forward, or do you and try to continue to get better? This has been, again, highly correlated with who improves, who gets over chronic pain. It takes a lot of work, and it's going to be a long journey, and it's easy to give up on the way. And it's really hard to maintain the self-efficacy if you've tried and tried and tried and keep getting defeated. So this isn't an easy thing to do, but it's important. Stress and depression. Not going to go too much over this, but just here's some suggestions for that if you suffer from those things. Okay. So we're going to get back to physical therapy for low back pain. And kind of, as I said, there's a lot of different treatment methods. Let's see if I can get... Give me 1 second. Can you guys see my pointer? No.
Yes, I can see it.
Okay, you can see it? Okay. Okay, because that makes this easier. So there's a lot of different treatment methods for back pain, and I think it's hard for people to understand where to start. And this actually, we're kind of differentiating between more acute pain over here and more chronic pain over here. So as we get out of the acute phase, then we kind of move over here. But if you have a flare-up, you kind of might go back to the symptom modulator stage. So what this says is that in the beginning, or when it's really, really, really irritated, yeah, you need to do things to calm it down. And doing a whole bunch of strength training at that point isn't going to be as helpful. As it gets less irritable, then we need to move into that. So I see people that are often stuck on these things. I see people that are kind of in these less severe levels of pain that are always looking for symptom modulation things. Or I see people that are they're in horrible severe pain and they're like, well, I need to do strength training. And what the research is showing is that if we kind of separate people into groups on what we do better and we have better results. So basically they switched around these groups and did research and said, what if we just mix up these exercises to different groups? And if you give a whole bunch of strength training to really, really severe people, they don't do as well. If you do a lot of manual therapy on people that are in very low levels of pain, they don't do as well either. So we're gonna get into this. We're gonna kind of go into these in more depth because these are kind of unique, and we'll go over these things as well. But I like the symptom modulation stage a lot and explaining that to people because that's your first aid. That's where you get back to when you have a flare up. So you're doing better. You start PT. We calm down your symptoms a little bit. We do some gentle strength training stuff, and then we move on to more aggressive strength training, and then you have a flare up. Well, then we go back to this stuff. Yeah, and we're going to go into this in a minute. So this is under kind of the symptom modulation stage. So we're going into that really severe, I'm really flared up. This is one of the first things we can do. This involves picking a direction to move, and we're gonna show a picture of these exercises in a minute. And these exercises are done 10 times every 1 to 3 hours. So it's just 1 or 2 exercises, and you do them a lot throughout the day. They're also known as McKenzie exercises. This is best for people that have radiating pain down the leg. And again, you're kind of in that severe stage. Lots of pain, horrible. McKenzie exercises are the way to go. So as I said, you pick one of these directions and you go with it, depending on how you respond. So if we have someone that's over the age of 50 and their imaging says that they have spinal stenosis, and when we do a lot of bending forward, they feel better, then we stick with this one. And we'll have you do this every hour. We also may adjust your posture by actually having you slouch a little bit more and relax those back muscles a little bit. If you're a little younger and you have a disc herniation, you don't have to have the disc herniation on MRI. That's not an indicative factor, but you have the pain that radiates down the leg. It radiates below the knee. And when we have you bend backwards, it feels better afterwards. Then you're going to do a bunch of extension. One important thing about this is generally this hurts while you're doing it, and it feels better afterwards. With this group, we're going to have them sit less, use a lumbar roll, and don't slouch as much. This lateral shift over here, this is the individual that they kind of wake up and they say, I'm crooked. And when they first get out of bed, and their pain is always down the leg, and it's always they're always kind of shifted away from that side that's painful. They're going to do these lateral shift exercises. Traction. Let's say you have leg pain, and you tried those exercises above, and none of them worked. This is when traction works. So if you just have a localized pain in your low back and it doesn't radiate below the leg, traction's not going to help. If your pain's not that severe and you're getting better, again, traction's probably not the way to go. This is, you're in that kind of early stage. I got to get out of pain. It's horrible. It hurts all the time. And I have pain down the leg, and everything I do makes it worse. Then we do traction. Spinal manipulation and mobilization. We have really good data on who's going to respond to this. So this is what people think of as chiropractic. But physical therapists, chiropractors, and osteopaths all use these techniques. They can be oscillatory or they can be a thrust technique. So they don't have to be one of those aggressive, cracking, rotating techniques. The people that respond really well to this, they're not very fearful of their symptoms. They had back pain that was less than 16 days. Remember, you could have acute on chronic. So if you kind of have chronic back pain, but you have an acute flare-up and you get them every 6 months or something like that, you still might be appropriate for being manipulated. No pain below the knee. Again, you're probably better off to do the McKenzie exercises. These exercises if you have pain down the leg. And then some of this other stuff is stuff that we would just look at as physical therapists. We do find that manipulation and mobilization is more effective than massage. And here's kind of what that looks like. Here's where the therapist is twisting someone. And sometimes we do that with kind of a thrust technique and you get a pop out of it. And here's where we're just pushing down on your back, on the vertebrae. Active rest. This is not commonly used. This is the patient just injured themselves. And for just a couple days, maybe a week, we're going to have them lay off of it. In the initial stages of a flare-up, the best thing may be to just not move around too much. But this doesn't last. It's important that this treatment doesn't last for very long, like 3 to 5 days, probably at most. NSAIDs, ice, bracing, taping, that's all stuff to do. This is every single thing you try hurts and it's awful all the time. So we're going to move out of, yeah. So the stuff we just covered is kind of where to go if you're, high level disability. Symptoms are just spontaneous and they occur all the time. And you really just can't move around much at all. Once you start to get past that stage, or if you never were in that stage, then we might be in kind of this movement control area. Most patients kind of come in between these two areas. So if you're doing a little bit better, pain's kind of intermittent, pain level is moderate, then we're going to go into kind of this motor control, movement control stuff. And that kind of looks like this stuff. This is the traditional stuff that we look at in physical therapy. Some of these tests down here are really physical therapy specific things. There's about these last three. What we do know is that who these type of exercise help most with is moderate levels of pain, less than 40 years old. Again, this is kind of the traditional stuff. We want to ensure good mobility and good strength. It's really more of a muscle timing issue than it is just a grip and hold thing. We need our muscles to hold and we need them to relax and we need them to turn on at the right time and turn off at the right time. A lot of the research you've heard about your transverse abdominis if you've been in the physical therapy arena for a while. A lot of what they found with that is it just wasn't turning on at the right time. So this isn't a tighten everything all the time. We need both strength and mobility. Functional optimization. Yeah.
I don't know if you want to bring it up now or at the end, but one of our participants wants to know the difference between pain and chronic pain.
Pain and chronic pain. Technically, chronic pain is only lasting over 3 months. Over 6 months is considered chronic pain. I mean, I'm really gearing this towards the people I'm most concerned about are people that have had it for years and years and years. 3 months for me still is not a long time, but 3 months will qualify as chronic pain.
Mm-hmm. Thank you.
Functional optimization. This is strength training. So after we do all the gentler stuff, after we do more of kind of the motor control stuff, tighten your abs and move your legs, then we really do want to do some strength training. And part of the reason I showed some of these exercises here is, as I said, people would be afraid sometimes of doing something like running or deadlifting. There is some research with deadlifting that actually shows that if you train people to do deadlifting that have chronic low back pain, they do better. This is, again, there's a therapist or a strength and conditioning individual working with them and doing this stuff. And again, they took individuals with back pain and they had them run. Over time, they did better. That doesn't mean if you haven't been doing any exercise at all, you should go run for 5 miles. That means that integrating this stuff in slowly over time is something that you should consider, and pick something you enjoy. If you enjoy aerobics class, then do aerobics class. If you enjoy Pilates, then do Pilates. Because I want you to integrate this into your lifestyle. Low back pain is multidimensional. So this is from an article called Cognitive Functional Therapy. And the interesting thing about this is Peter O'Sullivan. He's a Australian. He showed results that lasted for a year after therapy was discontinued, which is huge. Which really in the back pain world is huge. Most of the interventions that we have aren't effective beyond 3 months. And one of the things that he looked at is he looked at all the factors that were involved. So he looked at their belief structure. So what do you believe about your back? Do you believe that it's fragile? Do you believe that it's adaptable and strong? Emotional component. Do you have underlying depression and anxiety? Do you have depression and anxiety caused by your back pain? Which those can be two different things, right? Is it related to your body? Physical. So this has to do with loading strategies. So some of the McKenzie type exercises that I showed you before, or changing your lifting technique, or changing kind of how you sit and do stuff like that. Does that affect your pain? That's the physical right here. Pathoanatomical. So that has to do with your imaging. What does your MRI show? As I said, this isn't the end all be all, but it's not the end all be all because we have all these other factors. It's still important to look at, but it's not a good predictor on its own. Lifestyle factors. Do you sleep enough? Do what's your diet like? All those kind of things. Social. This is like how does your back pain affect your identity? How does it affect your ability to work? How does it affect your ability to interact with others? Sensory. So this is kind of like is there allodynia? Is there hypersensitivity? So if I touch someone's back, if I just touch their back gently like this and they jump off the table, well, we're not damaging tissue there. If they do some small little movement and they have horrible, horrible pain, and the x-rays show, hey, look, there's no fracture or something like that, we start to think that maybe the nervous system is a little sensitized, that maybe the nerves are kind of acting out of proportion to what's actually going on in the body. And again, that doesn't mean your pain isn't real. It just means that the alarm system is kind of overreacting. It's like, a leaf falls on the car, a twig falls on the car, and your car alarm goes off. No one's breaking in. Health. Do you have diabetes? Do you have heart disease? Are you obese? All those factors right there. And that's all I have for you guys. But now we're going to open things up, and you guys get to talk, and we'll discuss anything you want to discuss that we talked about today, or about your own individual issues.
Yeah, so we actually do have another question here. Any exercises that you can recommend for sacral or coccyx chronic pain? Also, any possible sources of sacral pain?
I'm thinking you're meaning like sacroiliac joint pain. There's some muscle energy techniques, and what I would say is that It depends on where you are. So if you're having a flare up, I would probably do more of those muscle energy techniques. I can show you. I think I can show you. You know, some of the ones, if you've been diagnosed with SI, you've probably been push into the knee, relax, push into the knee a little further, relax. If you're having an acute flare up, I would do those things. If you're more, if it's not as irritable, then I'd do more strength training. The SI and the SI stability is affected by the hip strength, the abdominal strength, the back strength, all of those things. Other questions? I'll look at the chat.
Yeah.
Okay.
When should you
When should you ask for more imaging? When you're ready to have, when you think that you need to have a procedure done. That's what I recommend to people. So are you willing to have back surgery? Are you willing to have an epidural? Has it gotten to the level where you're like, I need something more than just physical therapy? Then yeah, I would say, hey, you know, if you're having horrible sciatica and it's been going on for 4 months and you can't sleep and you can't live your life, then yeah, get an MRI because it's going to help you. It's the first step kind of to take to get an epidural. If you're just curious about what's going on, I probably wouldn't get it because it's probably not going to, having that knowledge isn't going to do anything for you. And it may be a little detrimental. Not all psychologists are versed in chronic pain. We can get you the name of a couple pain psychologists later that we recommend, but not all psychologists are versed in chronic pain. And it's a tricky thing because you have to understand a little bit about back pain to do that. Do injections in the knee help? They can. We're not going to get too much into that. Because it's kind of off topic, but yeah, they can. Some of the Synvisc shots, some of the PRP, cortisone, all that stuff has its use, but yeah. What other questions? And I think I can I unmute people? How do we unmute?
Yeah. Yeah, we can do that.
And should we stop the recording too?
I think that's the thing that's can also be helpful for those who, you know, haven't attended and
Okay. Okay.
have questions similar to this.
Yeah.
If it is something personal that you don't feel comfortable at all, I can definitely say it in the chat. But also,
Let me grab. I'm gonna find two.
Yeah. I have
Let me grab them.
yeah, I have a question. I mean, if you don't
yeah,
mind. My name is Caesar.
I see.
Yeah, I was just typing it, but I think it's better if it's just talk. It's
Sure.
faster, easier. I was just saying on my last question is like I have experienced chronic pain on my sacral area near the coccyx area, but I do not recall I ever had a direct injury to that area. So you know, the pains. I mean, it's been coming and going, but it's being mostly manifested when I lay down on my back. So basically, I cannot lay down on my back more than 10 to 15 minutes. And sometimes the pain may stay there for a long time, and sometimes it doesn't. So I try to sleep on my side, you know, but still, you know, and I've taken medications and nothing has happened. I checked with my doctor a couple years ago. I have a CT scan on that area. I didn't find anything. Only I think there was a very minor dislocated disc on my lumbar area, but it's very minor, and I don't have pain on my lumbar area at all. So
just in your SI.
You know, even when the doctor palpates in that area, on my sacral area, it doesn't hurt. But it's just when I lay down on my back, I mean, it's when the pain gets really bad and moderate to severe sometimes. So maybe any suggestions? I mean, anything?
What's your Are you exercising regularly? What are you doing regularly to keep yourself active?
Well, I have been attending um, therapy. I mean, the last 2 months for pelvic inflammatory syndrome. You know, even though I don't have any pain in that area, but it's just had like probably stiffness on my pelvic wall. So it has impacted my urinary system. I mean, sometimes it was difficult to empty my bladder. So, and so they're helping me, training me to relax my pelvic wall to diminish the symptoms there. And it's starting to work. I mean, it's slowly, but it's starting to work. But the pain on my sacral area, no, that's changed. I'm not so sure. That has nothing to do with it, but it's been kind of
only with it's not with activity.
No, it's just when I lay down on my back. It's like to pressure, basically.
And if you tried putting like a pillow under your knees at all?
Yes, I had, but no, it didn't help me really. No, I have thought like many causes that can be, because in that area, you know, there's the ascending column there, you know, nerves and everything. Because I had a recent colonoscopy, I think I was fine. It's negative. So I don't know what's going on in that area. I mean, I was hoping maybe if you hear anyone share with you any similar problems.
It's a little strange. I'd have to evaluate you to see. It's a little strange because it's only when you're lying down. You know what I mean? It's one of those atypical kind of cases, but it's not completely unheard of for people to have kind of pain with that. Normally, it has to do with kind of the position of the back. If you're laying flat on your back, like, does it help if your knees are up at all or not?
A little bit. A little bit, yeah. But I mean, then again, if I'm like on my back for a while, you know, it will start hurting again. So if I'm basically when I go to bed, I mean, I have to sleep on my side. Yeah. But then when you go to sleep, you know, you don't control of your position, you know. So obviously, I want to wake up on my back, and my back is hurting already. Yeah. So it's been kind of frustrating all these years.
Yeah. We'd have to look at you a little closer with that one, and talk to your therapist that you're seeing about that and see what they can do. Yeah, I'd have to evaluate you to look at that more specifically.
If you have any questions too, you can put.
I do. Yeah.
You can put your information, Cesar, in the sign-in sheet, and then I can reach out to you so we can at least get you connected, you know, to Jim or any questions you have in regards to our office as well.
We do. Yeah, I go to the one in Encino.
Oh, okay, perfect.
Yeah. So I have another question here. I wake up with low back pain, but once I'm moving it fine. It flares when I sit a lot or do a lot of gardening, but always lets up when I stop or change what I'm doing. So that sounds like you're flexion sensitive. What I mean by that is I mean rounding the back. So rounding the back, sitting like this, is kind of what's irritating for you. One of the things that I would recommend, besides sitting upright, besides getting up regularly, all that stuff, is probably these extension exercises right here. So this makes a lot of sense. If you're having pain after you're sitting for a long period of time, if you're having pain after you're bending forward for a long period of time, this is kind of where I'd go for symptom relief. And then, as I said, then I'd get into more strength training and stuff like that. But this would kind of be your first aid to do when you first get up in the morning, to get out of that pain. And then we get more. Then as it eases up, get into more of the strength training. Is there a connection between back pain and knee pain? I'm experiencing both at the moment. Not typically. If I see a lot of joints hurting, if you tell me both my ankles hurt, both my hips hurt, both my knees hurt and my low back hurts, then I send you to a rheumatologist. If it's just one knee and low back pain, yeah, it could be that you're compensating a little bit, you're walking a little bit, moving a little differently, or it could just be chance. But no direct question. Are you talking about pain that radiates down the outside of the leg into the foot? That's related to your back. That's absolutely coming from your back. That's probably not coming from your knee. If it's pain that radiates the whole way down the leg, that's not knee pain. That's nerve compression. And you find that child's pose when you get out of bed helps. Yep. Because I know who this patient is, but I'm not going to say it. But they're a little older, and they probably fit that stenosis category. So, older than 50 years of age. If we did an MRI, we'd probably find stenosis. Yeah. So, and then we'd train you, we'd strengthen the abdominals and stuff like that to kind of get you out of this posture over here, to get you, this isn't a posture, this is someone bending backwards, but to kind of round you over a little bit, get you out of some of that extension. What other questions do people have?
Did you have any apps or books that you recommend, Jim?
Oh, yeah. So this is, let me grab the other one first. Sorry.
These are all very great questions. I just wanted to thank everyone for asking. This is awesome, actually. And then if you have questions about our office and getting seen too, I can also put my email in there. You can send me an email anytime in regards to what we have going on there, helping you get an appointment. We take most insurances as well.
So if you have severe pain that radiates below your knee, and especially if it's like probably more, especially the people that are discogenic, but even the stenotic patients too. So the patients that are younger, horrible pain when they bend forward or they sit for too long, and then when they try to stand back up, they have horrible pain. I couldn't find my back one, but there's a book called Treat Your Own Back by Robin McKenzie. That'd be a good place to start if you're getting that pain down the leg. For kind of general chronic pain, chronic low back pain, especially if you're kind of fearful of movement and you've heard a lot of different things and you're trying to make sense of your back pain. Let me cover up the... Everyone Has Back Pain, and that one's by Adrian Lau. And then the other thing that I'd recommend is finding some form of exercise that you like to do and start to get more physically active. Exercise helps most low back pain. May not get rid of it completely, but it'll certainly help. What other questions?
Maybe if it's helpful to type the title in the chat.
Let's see.
I think there was one question. Do you ever find that patients have metastatic disease?
It's very, I think it's like 2% of the individuals with low back pain. It's not a high percentage of individuals with spine pain that have metastatic disease. It does happen, but it's not where I'd go first. You'd have to be, for me to think that way, you'd have to have like a history of cancer, pain that doesn't change at night, older age. So if we're like over 55 and you're saying, you know, my pain's really bad at night, I can't change positions and get rid of it, then I'd probably be sending you off for imaging. It's not what I think of first, because it's only like 1 or 2% of the population that comes in with low back pain that has bone cancer, and that's generally the one that'll cause back pain. Treat. And then I'll give you a third one too. Yeah. Bye.
Thanks. Yeah. Thanks to everyone who's joined
Yep.
in.
Any other questions?
Yeah,
Did
I
you
have
guys
a question.
get a lot out of this?
Yeah, I have another question.
Yeah.
When is it time to see a chiropractor? I mean, or is there any difference getting a chiropractic treatment versus physical therapy? Let's say in this case for low back pain, like on my case.
Physical therapists and chiropractors can both do spinal manipulation. I will say not a lot of physical therapists do spinal manipulation, though. What I would say is the people that are going to do best with that are individuals that are acute. They have less than 16 days. They've had back pain for less than 16 days. Where is it? They're not very fearful, because quick movements with people that are really, really afraid of their low backs doesn't work very well. No pain that radiates below the knee. And then this is all, the other two things right here are kind of physical therapy specific things. These aren't things that you would know. So the best people for manipulation are the recent onset of pain without pain that radiates below the knee. It can be effective for people that don't fit those criteria, but if you have those criteria, you have better success with those treatment methods. And again, physical therapists, chiropractors, and osteopaths all do manipulation, but not as many physical therapists will do manipulation. Is that helpful?
Yes, it is. Thanks.
Anything else? Did you guys get a lot out of this? Was this helpful? Okay, good.
Yep, and you feel free to give our office a call or shoot us an email if you have any more
my email. Jim.
As far as you know, maybe getting seen in the office if you aren't already. And then we take most insurances, and we do also offer telehealth. So
wait, I missed an S in there. Spinal cord stimulators. So I treat another condition called regional. They're tricky. It's spinal cord stimulators are a tricky subject. It's a device that is always going to be inside of you. You're going to have some pain initially from the stimulator implantation itself. If you're completely, utterly disabled, I have seen it do miraculous things, but it's not without its downsides. It's less invasive than a fusion, but then that you have that device in you all the time, and they don't work forever. So sometimes they fail. If you tried everything else, and it's a last resort, I would consider it, but only as a last resort.
Another question.
Yeah.
For low back pain, the use of TENS unit and IFC mode, I mean, what is your recommendation for that? I'm starting to use that And also, my other question would be, is as you know, it's like people with chronic pain, you know, they take pain medication, narcotics for long term, and body develops tolerance to it. I mean, it's not as effective as it was the first time. I wonder if there is something effect like this, well, using the TENS unit over a long term, you know, time.
I don't think you're gonna. Well, the bigger problem with opioids is, besides all the problems with opioids, with death and all of those issues and addiction, is what we'd call opioid-induced hyperalgesia. So we think that if you're on opioids for years and years and years, you may actually have more pain from it. That being said, you will go through withdrawal if you decrease it. So what they're finding when they take people that have had back pain for 10 or 20 years and they're on opioids, that if they take them off of their opioids, they're horrible and awful for the first couple of months. About 6 months later, after they've been off of them for a while, they may actually start to feel better. So opioids are really good. Like when you have surgery, they're really good for short-term pain, but they're not really good for long-term pain. And that's the research just has not panned out that they're effective for long-term pain management. There's other classes of drugs for that are helpful. SSRIs, some of the anti-epileptic drugs like gabapentin and some of those drugs. You have to talk to your doctor about that. I'm not a medical doctor. I can't prescribe medication. As far as TENS goes, it's not going to hurt you. It can give you some temporary relief, but realize it's temporary relief, and it falls kind of under that category of passive coping. If you're doing all the other stuff to help yourself and you want to use a TENS unit, go ahead. I'm not going to say don't do it, but if you're doing it instead of doing exercise, then I would say get on an exercise program. It's not going to make you better, but it can give you some temporary relief. Does that help? But I don't think you're going to develop a tolerance to it either.
Yeah, I do agree with exercises. Since I started doing the pelvic exercises, it has helped me somewhat with the pain. I mean, it's fairly new because I had this pain for many years, maybe 5, 6, 7 years. So I guess my expectation is, as I was told, to be more realistic. I mean, I expect to get pain relief, I mean, overnight. I mean, it may take a while to start getting some, but I feel like it's helping. Yeah, I agree with that.
Right. And just keep upping the, as it gets easier, just keep upping the exercise and increase the intensity. What other questions do we have? Anything? Are we done?
Yeah, I mean, we can stay if anyone has questions, but thank you everyone for joining us. It's so nice to hear from everyone and everyone's experience. Like, really, really do thank you. Thanks, Anastasia.
And I have a question. Was this helpful to you guys?
Yeah.
Did you learn something? Because I always, I know this knowledge, but I always like to know, is it helpful? So yeah, you guys got stuff out of this. Thought.
Yeah, it to me was it was helpful, especially my questions answered. Yeah, some of the stuff already knew or was familiar because by going to the doctor, I learned the stuff. You basically reinforce for what I know a little more. It was helpful. Thanks.
Good. Okay.
Yep. Thanks everyone for
done.
joining.
Bye. It was nice meeting all of you.